So this is the definition of massive transfusion. More than 10 units, more than 4 units, and these two some hand in hand. Replacement of 50% of blood volume, and if the rate of loss is more than 150 ml per hour. Okay, what is massive transfusion? Remember in your practice where you can find massive blood loss, ectopic pregnancy, placenta previa. Other conditions are also there, but you remember these things: ectopic placenta previa, uterine PPH, or other non-obstetric causes like ruptured splenic artery, hepatic trauma, and other traumas. Okay, so what do you do if a person came, if with massive blood loss or major hemorrhage? What you'll do? You do ABC. So uses the airway breathing. You'll administer the airway and breathing. Then you administer the circulation, that is 10 to 15 ml. So sorry, you'll administer the oxygen, that is 10 to 15 liter per minute oxygen per minute. Yeah, whatever oxygen saturation concentration, you should give oxygen. Then you'll do the circulation. You'll take a 14 gauge needle, then you'll withdraw the 20 ml of blood for all the blood tests, and you'll start giving IV fluids. IV fluids will give warm fluids. Okay, why you're giving warm? Because less temperature, low temperature hypothermia, it causes acidosis. Okay, transfuse blood as soon as possible. While awaiting for the PRBCs, you'll infuse 3.5 liters, at least up to 2 liters of fluid should be given. Okay, as soon as possible. If there is no crystalloids, then you can give 1.5 liters of warm colloids. Okay. So what are the different blood components? First is PRBC. It is 250 ml. 1 unit increase 1 gram of hemoglobin. Platelets is 50 ml. 1 unit increase 50,000 platelets. Cryopressed is 20 ml. 1 unit increases body weight for 10 kg of body weight increases 50 milligram. Okay, FFP is 250 ml again. Here, 1 ml of FFP has 1 unit of coagulation factor activity. So PRBC, you need ABO origin compatibility. Even FFP needed ABO origin incompatibility. Okay. Then WHO recommends IV fluid replacement for PPH is isotonic crystalloids. Then compared to colloids, crystalloids is best. What is the massive transfusion protocol? Early resuscitation with blood is needed. Tissue perfusion should be maintained and oxygenation should be maintained. And we should avoid hypothermia. Monitoring the vitals, Foley's catheterization. Some use TEG. In our hospital, we'll use TEG for in liver transplantation condition. But TEG in obstetric hemorrhages studies are being going on. We'll do APTT INR. We can use ionized calcium and blood EBG also. EBG, VBG. Basic standards is you should make the hemoglobin keep the hemoglobin greater than 8, platelets greater than 50,000. PT should be less than 1.5 times. APT should be less than 1.5 times, and fibrinogen should be greater than. Okay, so hemoglobin, platelet, and fibrinogen should be greater than. Okay. Next is blood components transfusion in massive hemorrhage. See, if there is massive hemorrhage and there is no blood, same blood group, then you can give O negative or K negative group. Okay. ACOG 2020 says that if you give 6 RBCs, then you should give 5 FFPs. Okay, this is a protocol, and you're giving 6 RBCs, right? So you'll give calcium gluconate as well. Okay, placental. If you're suspecting any placental abruption, hemorrhagic fluid embolism, then you can give FFPs. PTNR should be more than 1.5 times, I already told. And see, in case of massive bleeding, you can give 2 piles of cryopressed and 1 pool of platelets. Fibrinogen should be greater than 2. Platelets should be platelet count is less than 75,000. Then you will give platelets. Okay. Then obstetric hemorrhage nowadays, like in FIGO 2022, it shows that you can use tranexamic acid in the management of PPH. Okay. So they'll ask at what levels of platelets you'll transfuse the platelet. At what levels? If the platelet count is less than 75,000. Some people say that you can give vitamin K and injection IV. Okay, monitoring should be done, and I already told this tag is being controlled. Trials are being going on. Conclusion is we should maintain the hemoglobin and hematocrit estimated levels. Okay, so this is about second second topic in this bulletin, that is blood products. I felt in this thing is like we should discussion. We should find out what are the risk factors for hemorrhage. We should manage that, and some important topics like when to use which BT set and all. Very important. I felt this is massive transfusion. What is massive transfusion? More than 10 in 24 hours, more than 4 in 1 hour. Okay, then you have rate of loss of more than 150 ml per hour, or replacement of 50% of blood volume in 3 to 4 hours. And what is the amount of platelets and all, how much it will replace it. Um, that's it. Okay. Now coming to next topic is POCUS. If the question comes POCUS, then you should write the definition. POCUS means it is point of care. What is that? Point of care ultrasound. Okay. Basically, we'll do fast ultrasound. Na? That is one part of POCUS. Okay. So POCUS, something like in labor room, we should keep for this fetal presentation, cord presentation, amniotic fluid in potential complications to find out abruption, placenta previa and all. POCUS also helpful to find out the fetal heart rate, Doppler, growth restrictions and all. PPH also we can need. Like if there is a PPH, if you immediately you start doing POCUS, okay, you can find RPOC, utenotony, hematomas, pelvic collections and all. Okay, early referrals can be done. So these main focus is to keep ultrasound even in rural areas. Some people can find, some people like it's one of the component like IVC assessment can be done. If IVC is collapse, that means it is hypovolemia. If there is IVP distended, that means there is elevated CVP, central venous pressure. So dynamic monitoring can be done. Cardiovascular assessment like heart also they can find out. Okay, heart valves and pericardial effusion they can find. Even respiratory lung ultrasound can be done. Like pulmonary edema, pneumonia, pleural effusion can be seen. B lines are seen in pulmonary embolism. Okay, then pleural effusion can be seen as anechoic fluid. Consolidations in pneumonia, wedge-shaped pleural consolidations are seen in pulmonary embolism. Normal consolidation pneumonia, wedge-shaped consolidations is pulmonary embolism. Even CNS assessment can be done by ultrasound, but CT and MRI no one can replace. Transcranial Doppler can be seen. Optic nerve sheath diameter is seen. In raised ICP, the optical nerve sheath diameter is increased. Jugular veins also we can find out by means of ultrasound. Emergency and trauma situation you can do E-FAST. What is E-FAST? Focus assessment with sonography for trauma. Here these are different planes where we see like perihepatic, then perisplenic, pelvis and thorax. Okay, appendicitis, acute abdomen obstruction, bowel edema can be seen with this E-FAST. Procedural guidance is we can even central venous line can be inserted by means of ultrasound and it is also focus. And some procedures like thoracocentesis, paracentesis, pericardicentesis can be done. Then then you have non what is this? Benefits of focus is immediate results can be seen, diagnostic accuracy, dynamic assessment, and no, there is no ionizing radiations, non-invasive, portable. It comes to the patient, cost effective. Even if we don't have any, if we don't know, then we can just do ultrasound, send images to consultants. Okay, from specialists we can get guidance. Challenges is we should take informed consent, confidentiality, training, some PCP and data acting because of female feticides this will affect. Okay, so medical devices rules are there. So for example, for registration licensing also they should have registration, then only we can provide focus devices. Okay, that's about focus. Next up is ventilator supporting critically ill patient. uh, there is nothing new in this. Like see if the person is cannot breathe or may not maintaining the oxygen saturation levels properly, then we'll do ventilation. Okay, so there is a there are different conditions where we can expect ventilation. One is pregnancy-induced hypertension with pulmonary edema and ARDS. Okay, like in pregnancy-induced hypertension, there are complications like encephalopathy and HELLP syndrome, where they require ventilation. ARDS is also required. Some people give magnesium sulfate if there is toxic levels like more than 12, then there is respiratory arrest, and also we'll do ventilation. Ventilation. There is Berlin's definition of ARDS, like within first week you have respiratory symptoms. On chest imaging you have opacities, respiratory failure not explained by cardiac failure. Um, Need echocardiography to exclude the hydrostatic edema. That is impaired oxygenation. Okay. Mm, So I mean to say that particle oxygenation should be more than 95. That is the main goal of ventilation. Okay. If someone asks what is PaO2, PaO2, then you say it is 60. Okay. What is PaO2? Then that is 60. Okay. That's it. Don't remember others. We'll just confuse. Okay. Point of that is focus also you can use in ventilation. That's it. Non-invasive ventilation is we don't use any endotracheal airways, just will give non-invasive ventilation. So obstructive airway disease, it is useful in case of pregnancy. Cardiac failure is the most common cardiovascular complication. It requires ventilation. Sometimes we can use left lateral tube to decrease the relief of compression by uterus on IVC. So inverse ratio ventilation. So if generally the inspiration to expiration is 1:2. So we'll reverse it. We'll increase the inspiration. Okay, so alveolar requirement increases and oxygen diffusion will be increased. Prone ventilation is also COVID time. There's been more popular. ECMO is also seen. It survival about 80%. That is extra corporeal membrane oxygenation. Okay, then yeah. Most of the people will be using this mnemonic to find out what are the daily checking. Daily, they'll write this fast hug in their case sheets. Fast hug is feeding. If there is feeding via jejunal tube or not. A is anesthesia using short acting opioids or not. Sedation. S is sedation. T is thrombosis prophylaxis like low molecular weight heparin. Head end is elevated or not. Use also prophylaxis is given like proton pump inhibitors like pantoprazole is done or not. Then G is glycemic control is done or not. Okay. So for sedation, generally they give propofol. Okay. And short acting opioids like Ventil can be used. Weaning from mechanical ventilation, gradual step down you'll do. Okay. Minimum CPAP support to TPs can be given. Okay. Conclusion is multidisciplinary team will be acting and we should optimize the carbon dioxide level to 20 to 32 mm. Lung low tidal volume ventilation should be provided because it can cause barotrauma or volume trauma to the lungs. So that to be taken. Next topic is quality improvement initiatives. This is also nothing new. Structure, process and outcome. So we'll see that is known as Donabedian model. Okay. It is not nothing new. There are new points in this topic, but it is mostly of like preventive medicine type. Okay. So we'll use key initiative is friendly signaling system and early recognizing like Q-SOFA, OMS Q-SOFA. Mini pipers is the one which is used for preeclampsia. Okay. For referrals and all, we'll use some protocols, computer-based training drills for shoulder dystocia. Multidisciplinary collaboration is required. For PPH also, AMTSL should be done. These are all different protocols being given to improve the quality of life. Maternal sepsis prevention, blood bank services, resource management, life-saving anesthesia skills. These are also training. Okay, basically this topic says that we should give training to the individuals. Even ANC and ASHA workers should be given. Contraception also should be educated to the patients. Okay. Um. Yeah. So in this topic above, I felt important is ventilation. Only few points and focus is I think it's a expected question. Okay. I think you can write this point of care ultrasound. Thank you.